Good evening, everyone. Today, the topic of presentation is the management of diabetic ketoacidosis. We all know day-to-day in emergencies how many cases of diabetic ketoacidosis is we see in day-to-day practice. So, what is diabetic ketosis? How is it actually occurring in a patient? So, diabetic ketosis is actually occurring in a patient because there is an altered ratio of insulin to glucagon. So, when there is insulin deficiency and the elevation of the counter-regulatory hormones, especially glucagon, there is increased lipolysis, gluconeogenesis, glycogenolysis. Because of this, the ketoacids are more synthesized. So, this is causing diabetic ketosis. This is mainly due to the altered ratio of insulin to glucagon. Insulin is decreasing and glucagon is increasing. And it is mainly seen in type 1 diabetics because there are absolute insulin deficiency in type 1 diabetes. It is not seen in type 2 diabetes because they have some amount of insulin in the body to preserve the anabolic function of the body. So there won't be complete alteration of insulin glucagon ratio in type 2 diabetes. So most of the patients of diabetic ketoacidosis presentation are type 1 young patients coming into the emergencies. So with this brief discussion, we will go into the case-based scenario approach of diabetic ketoacidosis. So first case is a 19-year-old female, known case of type 1 diabetes mellitus for 2 years on basal bolus regimen. So what is basal bolus regimen? Basal bolus regimen is one, there is long-acting insulin, that is either degludec or glargine, or you can use NPH, intermediate acting insulin. And bolus is whatever we are using for the prandial spikes, that is regular using or aspart or lispro, whatever it is. So combination of both long acting insulin and short acting regimen for the bolus for the prandial coverage is called basal bolus regimen. So, and patient is now admitted with the sugars of 540 milligrams per deciliter, and also pH is 6.9 and bicarb is 6 milliequivalents per deciliter, and serum electrolytes are 127 milliequivalents, and also potassium is 3. That is 3.2 milliequivalents per deciliter. She presented in altered sensorium. How do you manage this case? So first thing, we know the sugars are very high, 540, and pH is also 6.9 and bicarb is also lower side. So with this we can reduce that the patient. How do you diagnose a DKA case is one, there should be 3 factors. One, sugar be more than 250, urine ketone should be positive, and bicarb should be less than 15 to 18. That is metabolic acidosis with increased anion gap. So here we can clearly see 2 factors. So any of the 2 of the 3 factors, that is either metabolic acidosis or sugars more than 250 or urine ketones positivity. Any of them in the 3, any of the 2 is positive is enough to diagnose a DKA case. So this is clearly a DKA. So why are the electrolytes? So sodium is 127 and potassium is 3.2. So how does this matter? And she is an altered sensorium. So we all know how hyponatremia can cause altered sensorium. So do you attribute this altered sensorium to hyponatremia in this case? Yeah, you might attribute this altered sensorium to hyponatremia in this case. But the problem is whenever the sugars are very high, so there is pseudo low levels, pseudo hyponatremia in the body. So for every 100 milliequivalents, 100 milligrams per deciliter increase in glucose, there is 1.6 milliequivalents false drop in sodium. So actually here sugars are around 540. So let's say average the sugars will come down to 140 or something. So there is 400 increase. So 400 into 1.6, it is almost equal to 1.6, 3.2, it's 6.4. So it is almost coming to 127 plus 6.4, it is almost coming to 133. That is actually normal. So whenever you are taking in the background of a hyperglycemia, you should always correct the sodium. For every 100 milligrams, we should add 1.6 milliequivalents of sodium to the existing value so that you will collect a corrected sodium value. In this case, it is almost around 133 milliequivalents. So it's actually normal in this case. So why is potassium 3.2? So since we know this is the case of DKA, how do you manage this case? So most of you will be jumped up on to start insulin therapy in this patient. That is why the potassium is very important. So all the guidelines says any potassium less than 3.3, you should defer giving IV insulin, subcutaneous IV insulin therapy in this patient. If you want to give in the case of milder DKA or something, you can try subcutaneous insulin, but IV insulin is not advised in these patients. So at this age, until you correct the potassium is more than 3.3 milliequivalents per deciliter. So first, what do you do this patient? First, for any primary case of diabetic ketoacidosis patient, first line management is always giving fluids to the patient. So initially, in the first 2 to 3 years, you should give around 2 to 3 liters of normal saline to these patients. Then you can go and start correcting the potassium also around 40 to 80 milliequivalents IV TID or something around 10 to 20 milliequivalent per hour. If it is a peripheral line, you can correct around 10 milliequivalents per hour, 10 to 15 milliequivalents per hour. If it's a central line, you can give it a 20 milliequivalents per hour. So first you correct the potassium, you give around 40 to 80 milliequivalents, bring up the potassium to more than 3.3. Until then you give the fluid bolus. Around initially you start around 2 liters of normal saline in the first 1 to 2 hours, around 2 to 3 liters around the first 2 to 3 hours also you can try. Then you can continue on giving around 100 to 150 ml per hour infusion continuously. So the primary management of DKA I want to know is give the fluid replacement is the primary management in the DKA, not the insulin therapy. So first you correct the hypovolemia in the patient. So that is by giving the proper fluid management in this patient. So whether you give bicarb in this patient or not. So here, if the patient has shortness of breath, is very tachypneic, is in respiratory distress, since the indications of giving bicarb in this patient is any patient, any adult patient mainly, children, bicarb is not advised proper per se because of the instance of cerebral edema. In adults, if pH is less than 7 or bicarb is less than 10, the patient is in respiratory distress, you can give bicarbonate correction therapy. How much bicarbonate correction therapy I will explain later. So first initially in this patient you give fluid challenge, then correct potassium, bring the potassium more than 3.3. Now potassium is more than 3.3 milliequivalents. You have completed around almost 2 liters of normal saline, then you are putting on 100 to 150 ml per hour. So will you correct normal, will you continue normal saline or you continue 0.45 per NS? It is up to your call. So if the patient is going into hypernatremia because of the bolus you are giving, you can give half NS therapy in this patient. So based on the sodium level, whether you give normal saline or half normal saline, it is due to the based on the sodium levels. So next thing, so now the patient is on fluid challenge, now the fluid therapy and also the bicarbonate therapy you can give since the patient, if the patient is in respiratory distress, since it is meeting pH less than 7 and bicarb less than 10. So now we corrected the potassium, now after repeat of 4 hours, potassium gone up to around 3.8 milliequivalents per deciliter. So now you can start insulin therapy. Insulin therapy is start at 0.1 unit per kg per hour. Let's say this is the 40 kg female. So you give 4 units IV bolus followed by 4 units per hour of insulin infusion therapy. So then you monitor sugars. So after giving 40 kg female around 0.1 unit kg per hour, that is 4 units IV bolus followed by 4 units per kg per 4 units per hour insulin infusion therapy. Then you monitor sugars. So for every 1 hour there should be a drop of 50 to 70 milligrams per deciliter. So if the starting sugars around after 4 hours, let's say the sugars are around 480. So next at the 5th hour sugar should drop to 420 or 410. It based on 410 to 430. It should drop at least by 50 to 70. So if the sugars are not dropping per se at that rate, you should increase the insulin drip rate. That is the 4 should be made to 8 or something. Actually as per the guidelines, at least you can increase to 6 to 7 units per hour. You can make it 8 also if the sugars are very high. So that is how. If the fall in the sugars value is not significant, that is at least 50 to 70, you should always increase the insulin drip rate. First thing, you should check the viability of insulin first, whether the insulin is properly stored or if it is kept in the room temperature for a long time, maybe insulin is not working. You should try to replace with new vial and again try again. If still that insulin is not the problem, you should increase the drip rate. Next thing. Then the next problem, if it is increasing, whether you should decrease the drip rate or not. Let's say after at the 4th hour the sugars are 480 and at 5th hour it came down to 410. Okay, sugars are decreasing, the drip rate is continuing at 4 unit. Whether you will decrease the insulin drip rate or not. So when the patient sugar drop to 410, you should decrease the insulin drip rate also. At what rate you should decrease? The guideline says 0.02 to 0.1 unit per kg per hour. On an average for him you can decrease around 0.5 units or something around that, 0.5 to 0.4 to 0.5. Slowly decrease the drip rate until you reach the 250 mark. So by then the drip rate will decrease around 2 units or 1.5 units per hour. Actually you should decrease the drip rate slowly. So with that, then at around 250 you can start dextrose infusion or ringer lactate saline, or based on the sugar monitor you can or a ringer lactate or continue half NS and decrease the insulin drip rate further. You can decrease to 1.5 at 1 unit per hour and continues the insulin infusion and maintain the sugar until the acidosis resolves, that is bicarb more than 18, pH more than 7.3 and patient is hemodynamically stable. So until all the causes are corrected, you should continue the insulin infusion therapy. So that is insulin at the rate of basal rate around 1 to 1.5 unit per to maintain the target sugar around 200. You maintain. If the sugars are falling more, you can decrease the insulin drip rate and add dextrose or something. If sugars are maintaining with 1 unit per hour, maybe sugars are maintaining at 200, you need not add a dextrose or DNS therapy. If they are maintaining around 200, 250, you need not add DNS. You can continue NS therapy and continue drip rate of 1 unit per hour. If the sugars are falling to less than 160 or 150, you can add DNS therapy along with insulin therapy to maintain the normal sugars. So that is how you manage this case. And once, and if you stop potassium infusion, as although potassium is around 3.8, since you are giving high amount of insulin to this patient, you should continue adding potassium to the fluid therapy. Generally we give around 10 milliequivalents, brother. So we can add 20 milliequivalents in every alternate hour or something like that. You can add continuously 20 milliequivalents in alternate fluids, or 40 milliequivalents in one every fourth hour. Like I prefer 20 milliequivalents in every alternate urine, 20 to 40 in every alternate fluid based on the potassium level. Until potassium is more than 5.5, the potassium supplementation is not contraindicated, or 5.5 or 5.2. So potassium supplementation is not contraindicated. So even though the patient is normocalemic, should continue potassium supplementation, because we are giving lot of insulin to the patient. It causes potassium influx, so the patient is prone to have hypokalemia. So potassium supplementation should be continued, though potassium is between 3.3 to 5.2. So that is the next guideline. More than 5.2 you can stop and wait if until the potassium falls, then you can give potassium supplementation. So what did you learn from this case? Though it is a 19-year-old female, type 1 diabetes, is on basal billet, sugars are high, you diagnosed as DKA, sodium needs to be corrected, that is 1.6 milliequivalents for every 100 milligrams. Since the potassium is low, you should start with fluid therapy and correct the potassium. See, potassium once more than 3.3, you should start insulin therapy around 0.1 unit per kg per hour. Then put the same as bolus, like 4 units if you IV bolus, followed by 4 units per hour. You continue until the sugars drop by 50 to 70. If the sugars are not dropping, you should increase the insulin infusion rate. If they are dropping, you should slowly taper the insulin therapy to the basal rate around 1 or 1.5. Sometimes it comes less than 1 also. To maintain sugar around 200 to 250, you should continue the insulin infusion therapy until the acidosis and hemodynamical stability is attained. And also potassium supplementation should be continued, though potassium is normal too, because we are giving lot of insulin until as long as 3.3 to 5.2 potassium is maintained. So this is the thing. So how do you overlap this case? So let's say we are giving around, patient is requiring around 1 milliequivalent per hour. So we kept the insulin drip rate, sugars are maintaining around 180, 160, 180, 190, or let's say around that is maintained. How do you manage this case? So we should count the last 6 hours of insulin infusion. Let's say 1 unit per hour is the last infusion rate. So for 6 hours it's 6 units. 6 units for 24 hours, it comes into 6 into 4, 24. So for 80% of it, so 80% of it for 24 hours, it comes around 20 units per hour. So with that around 20 units, you take 30 to 40% is given as basal regimen. So that is glargine or degludec. Let's say 20 units, you give around 8 to 10 units of 8 units of glargine. Remaining 12 units you give as bolus regimen. That is 4 units morning, 4 units afternoon, 4 units night. So that is how we actually overlap. So in order to overlap in this way, you should actually decrease the insulin infusion rate slowly and bring it down to the basal rate. So if it is not possible, you can go with the overlap of 0.8 units per kg per hour. Let's say this is a 40k, you get 32 units, 0.8 units per kg or 32 units. So you make it half, around 15 units of 14 units of glargine. You get remaining 868 you can give of Nova Rapid. That based on the remaining 16 units or 18 units you can give as a Nova Rapid or regular based on the availability of insulin per se. So best if you are overlapping from the infusion regimen, last 6 hours of how much requirement is here, you multiply into 4 to make it 24. Let 6 into 4, 24, and you make it 80%. In that 30 to 40% you make it as a basal regimen. Remaining you give it a basal regimen. Let's say 1 unit per hour, 6 units, 6 into 4, 24. Of it 80% is 20. 8 units is given as basal as 4 is there. If you are not able to get properly, if you are not able to properly monitor, you can go for 0.8 units per kg per hour or something. You can give it overlap based on the weight. That half, at least 40% is given. 0.8, 32 units, half 40% is given. 14 units gives basal, remaining you will give as bolus based on the availability of the how much did you monitor. So this is this case. Next case 2. A 55-year-old male, known case of type 2 diabetes mellitus and on oral hypoglycemic agents, now present with sugars of 620 milligrams per deciliter in altered sensorium, ABG is 7.23 and bicarb is 17 milliequivalents per deciliter. How do you manage this? So what is this case? Is it a DKA? See here the pH is 7.23, bicarb is 17. It's not severely metabolic acidosis also. Sugars are high, though they didn't mention urine ketose, but patient is an altered sensorium. So generally type 2 diabetic patient generally doesn't go into decay. It's unlikely the patient of type 2 diabetes going to decay. They can go when they become severely insulin deficient. So first thing you should do in this case, hyperglycemic hyperosmolar coma is the first thing I will make a difference. Further, the treatment is same. You give fluid therapy and insulin therapy the same way based on the potential you continue. But for this case, I will suspect more of HHS because of the background of altered sensorium. There is no severe metabolic acidosis per se. pH is more than 7.2 and bicarb is also more than 7. It's not looking like DKA, and the sugars are on the higher side. So I will bring him to hyperosmotic coma rather than the per se DKA. So the management is same. You give insulin therapy and fluid management in the same way. You replace, the patient will recover from the coma. So that is one point. So type 1s will have more of DKA presentation, whereas type 2, unless they are severely insulin deficient or something, they might not go into DKA per se. And also one more thing, when you are looking at DKA, you should always look for what is the cause of precipitation of DKA. Whether it is an infection, whether there is skipping of insulin, whether it is a dietary habit, whether some MI or CVA or unstable angina or some pancreatitis, any systemic cause can trigger a DKA. So you should always look for the cause. You should always treat that cause also while you are treating a DKA case. So that is also very important in managing a diabetic ketoacidosis case. So case 3, a 11-year-old child presented to hospital with the sugars of 336 milligrams per deciliter and pH at presentation is 7, bicarb is 13 milliequivalents per deciliter and was started on fluids and given bicarbonate therapy for acidosis. Patient sugars came down and acidosis improved, but patient was in altered sensorium. How do you approach such case? So as we said, discussed in the previously, DKA has 3 things: sugars more than 250, matching that case; pH less than 7.3, matching that case; urine ketones though mentioned, since 2 are present, already we managed. Patient was managed with fluids, initially 1 to 2 liters we can give as a bolus, 2 liters we can give as bolus, then 100 to 150 ml per hour given. Insulin therapy is given at 0.1 units per kg followed by infusion. So what they add on is they give bicarbonate therapy for this patient. So generally what we do in is pediatric case, we generally defer giving bicarbonate in the patients because bicarbonate causes fluid retention and provokes more of hypokalemia. So in that patients, in any pediatric patient, we defer giving bicarbonate therapy in patient. So we give bicarbonate. So the patient has already been given bicarbonate, insulin infusion and potassium correction, everything was done. Sugars came down, acidosis improved, but patient was in altered sensorium. What is the cause? So since the main point is, since though we advise bicarb is can be given in adult patient, bicarb can be given in the adult patient for pH less than 7 and bicarb less than 10. So since it's a pediatric case, sure, this bicarbonate therapy might have caused fluid retention and might have caused cerebral edema in this patient. So it is always cautious in a patient of pediatric age to give bicarbonate in caution. In per se, in adult patient also don't unnecessarily give unless the patient is in respiratory distress and severely acidotic, like bicarb less than 10 and pH less than 7, give it. Otherwise, don't generally routinely start giving bicarbonate therapy in every patient. So this is the one more. So this patient might be actually in a case of cerebral edema. So this is due to the bicarbonated fluid overload. This might be the cause in this case. So this is one thing I want to highlight in this pediatric case. Case 4. A 24-year-old male, known case of type 1 diabetes mellitus, was admitted to emergency with complaints of vomitings and pain abdomen. His sugars are 180 milligrams per deciliter or pH is 7.1, bicarbonate is 13, urine ketones were positive, potassium is 3.8 milliequivalents per deciliter, and patient is alcoholic and hasn't eaten anything since last 16 hours and his MLH is 380 units per liter. How do you manage this case? So will come from point 1. He is a known case of type 1 diabetes. So there is a chance of DKA. His sugars are 180, pretty much less than 250. That is not meeting DKA. pH is acidotic. So there is metabolic acidosis. We don't know about the anion gap. Maybe increased anion gap also will take. Urine ketones are positive. So it is meeting criteria of DKA. So potassium is 3.8. So we can straight away start, okay, let's have fluid therapy, let's start insulin therapy along with potassium supplementation out of the 20 milliequivalent per liter per hour or something. We will manage this case as DKA. That is a possibility. But patient is alcoholic and hasn't eaten anything in the last 16 hours and his ML is 380. So they have 3 different highlighting points in this case. 1. Alcoholics can be prone to acute pancreatitis. So MLH is already elevated. Do you treat this case as acute pancreatitis or not? And patient hasn't eaten anything in last 16 hours. So patient might be in the starvation ketoacidosis and also alcoholic ketoacidosis is also possibility. So these are all the very close differentials of diabetic ketoacidosis. Both alcoholic ketoacidosis, starvation ketoacidosis is very close differential, and in this case acute pancreatitis is also possibility. So how do you approach this case? So first I will go into the MLH point. MLH is 380 units per liter. So MLH is elevated. So per se in diabetic ketosis, there is elevation of the MLH levels because of the salivary secretion of MLH. It need not be in the pancreatic secretion. Salivary secretion of MLH is elevated. Because of that, there is an elevation of MLH per se. So this is a false positive. So it doesn't mean there is a pancreatitis. It can be DKA related only. So to diagnose a case of acute pancreatitis in a patient of diabetic ketosis, you should always get specific marker serum lipase in that patient. And also, you should get get an ultrasound or CECT abdomen if needed. So solely based on amylase levels, you can't diagnose the case of pancreatitis in a diabetic ketoacidosis because they're always elevated because of the salivary secretion of amylase, not due to the pancreatic secretion. So this might not be a pancreatitis, might be also. You should get a serum lipase and ultrasound abdomen to further evaluate for cause of pancreatitis. So can this be a starvation ketoacidosis? Can this be alcoholic ketoacidosis? Generally, starvation ketoacidosis and alcoholic ketoacidosis also cause metabolic use, but their bicarb is generally more than 15 milliequivalents per deciliter. That is always a possibility. Starvation ketoacidosis and alcoholic ketoacidosis is always a possibility. You should always keep in mind when patient doesn't, after giving insulin infusion, sugars are controlled, still there is small amount of acidosis that is not correcting, you should always suspect starvation. You should start feeding the patient, then the patient starvation ketoacidosis might resolve. So in this case, this mostly first should be managed as DKA. If the once bicarb is still not recovering after more than 50, it is becoming more than 15, still not recovering, you should start feeding the patient, then patient can recover completely. So in this, the close differential is always starvation and alcoholic ketosis. Since the bicarb is more than 15, there is severe acidosis in this patient, might be more likely DKA. There is always a possibility of starvation ketosis, but second option. First you should treat as DKA, then look after the starvation part. So that is what I will mention in this case. So we have learned a lot of points today. One, we have always learned DK, we have seen of DK, we have seen HHS case, and also in this case you can always see the sugars are normal. This is euglycemic DK, which is not commonly seen in the patients of SGLT2 inhibitors. So though this is a young female, he is having normal sugars and glycemic ketosis. Generally always when a patient is an SGLT2 inhibitor, his sugars may be normal, but patient may be in the severe acidosis. So when the patient in SGLT2, you should always keep in mind, you should get an ABG done and ketones done. So patient might be in euglycemic ketoacidosis. So in this table you can see, you have seen a case of DK, you can see a case of HHS and euglycemic ketoacidosis also. So you can see clearly here sugars are more than 200 to 250. Here HHS 600 to 1200, they are very high. Here sugars are less than 200 to 15, they are very normal range. Sodium can vary. One of the most significant marker is the bicarb less than 18. DK has severe acidosis. Generally HHS will have more than 18, and also euglycemic ketosis also near the DK. And also in HHS the pH is more than 7.3. Generally not significant acidosis is seen in HHS, but significant acidosis is seen in the case of DK and euglycemic diabetic ketoacidosis. So that is the major, and osmolarity significantly increased. HHS the osmolarity, if you count the serum osmolarity or measure or calculate osmolarity is 330 to 380. The main problem is hyperosmolarity in the HHS. So there won't be much of severe acidosis in this patient, but there is more of hyperosmolarity in this patient. So that is the most significant differences. One is the pH is significantly affected in DK and euglycemic regulation, whereas pH is less 6.8 to 7, but pH is almost normal in HHS. Bicarb is also almost normal in HHS, whereas DK bicarb is less than 18, but osmolarity is per se increase in HHS, and sugars also on very high side, that is 3. In our case they are 640, here 600 to 1200 is a possibility. So these are the markers which suggest HHS, generally seen in type 2 diabetes and elderly people. So next, manifestation of diabetic ketoacidosis. So ketoacidosis can present as nausea, vomiting, osmotic symptoms, abdominal pain, shortness of breath, anything. You should always look for precipitation. One, this can skip the insulin. One is infection. Any MIR, CVR, anything can cause pancreatitis. Any drugs can also, cocaine can cause, pregnancy can prefer. So physically you can find tachycardia, tachypnea, dehydrated, abdominal tenderness, obtundation. These are all common findings you will find in day-to-day practice. There is nothing much to add. I can add on to it. So these are the findings. You should always look for the precipitating cause. You should always treat that cause. So as I can tell you can clearly highlight this point. In DKA, the amylase is of usually of salivary origin, thus it is not diagnostic of pancreatitis. Serum lipase should be obtained if pancreatitis is suspected. This is what I mentioned in the fourth case. Though amylase is elevated, you should always get lipase and ultrasound abdomen to diagnose a case of pancreatitis. So this is also the measured serum sodium is reduced as a consequence of hyperglycemia. This is seen in the first case where 1.6 milliequivalents reduction in serum sodium for every 100 ml. So you should always add 1.6 milliequivalent for every 100 milligram per deciliter increase. So in our case there is 127, we added 6, it came on to 133. So these both points should always remember in day-to-day practice. And also one is differentials of diabetic ketosis is always alcohol and starvation ketoacidosis. So generally bicarb is more than 15 in both of them. So less than 15 you should treat it as DK, as sugars are more, then look after starvation ketosis. What we see is in most cases after you give insulin infusion, fluid therapy, some patient might not resolve ketosis, like bicarb will be 17, pH will be 7.27 or something. Maybe because of DK will keep them on fasting, NBM or something, the patient won't eat anything. Once they start feeding, no, maybe that small part of his dose may resolve. That might be due to starvation, because if the patient is not eating anything, so they have to obtain energy by the keto lipolysis or digluconeogens. Maybe they are synthesizing the acids. So at that time, maybe the starvation might be the cause. But primarily when the bicarb is less than 15, BH is 7.1, as we have seen in the first case, like the fourth case. So in that, the DK is the first possibility. You should treat as DK. If still bicarb is a little bit of acidosis, then you can think of starvation or alcohol other causes. So that is what 2 points I want to highlight. So this is the basic management. First, you should confirm the diagnosis with increased serum. Always, generally we measure the keto acids in the urine, but the blood serum markers, the serum ketones are more elevated. They are more significantly elevated. They should be measured, but it is not actually practically possible to measure the serum. But always remember, serum are more elevated. That is beta hydroxybutyrate is the more elevated marker. And admit to hospital with pH less than 7. We should always measure electrolytes before going. Potassium, sodium, magnesium, chloride, pH, everything should be measured. There is always chance of hypokalemia, hypophosphatemia, hypomagnesemia is a possibility. But potassium is a significant marker. We should only measure. But phosphate, magnesium are also decreased in DKA per se. 2 to 3 liters of 0.9% saline over first 1 to 3 hours. Then you should continue at 250 to 500 ml per hour. Then followed by 100 to 150 to 200. Once sugars are less than 250, you can add ringer lactate or normal set based on the maintenance. Like you can titrate 1 unit per hour. You can continue. Then you can actually, if the sugars are still falling, you can add a DNS therapy or something. So 0.1 unit per kg per hour, you can continue it. And if serum potassium less than 3 points, first you should correct the potassium therapy. Then you should add the insulin therapy. This is 1 point. And assess the patient. If there is infection or anything, you should always treat that. Measure glucose every 1 to 2 hourly, and electrolytes and ABG every 4th hourly, and blood pressure, respiration pattern every should be measured 1 to 2 hourly. So here you can clear this. Even though potassium is between 3.3 to 5, you should at least add 10 milliequivalents per hour of potassium, because we are giving high amount of potassium. Even if the potassium is less than 3.5 or 3, we should add at least 40 to 80 milliequivalents per hour. This is a Harrison statement. If the potassium is more than 5.2, you can just monitor the potassium. You did not give any supplementation. So sugar should be brought down. If the potassium, if the sugars are continuously brought down by 50 to 70, you can actually decrease the slowly decrease the insulin infusion rate to 0.1 unit per kg per hour, 0.02 unit per kg decrease. So you can actually decrease the insulin regimen. So how do you overlap? So as the first points, the fluid therapy. I'll highlight all the points. First therapy is you should diagnose. First there is acidosis. There is elevated sugar more than 250. pH less than 7.3. Bicarb less than 18. There is urine ketone. You diagnose a DKA. Fluid therapy is the main. First 2-3 liters and first 2 hours. Then followed by 200 to first initially you can get 250 ml per hour. Then followed by 100 to 150. You should maintain sugars around 150 to 200. Based on the insulin, you can actually decrease the insulin infusion rate slowly. And if still the sugars are falling around 1 unit per day, slowly you can decrease to 1 hour based on the weight. 1 unit per hour, you can actually decrease insulin. If they are maintaining normally, you can continue. If the sugars are still falling, you can add DNS therapy. Potassium should always be monitored. If less than 3.3, you cannot add insulin therapy. You should first correct the potassium, then add insulin therapy. Even though normokalemia is present, you should still add potassium at 10 milliequivalents per hour. If more than 5.2, you can just monitor. Then bicarb can be added in especially in adult patient, pH less than 7 and bicarb less than if the patient is respiratory distress. Then patient should always, the respirating factor should always be treated first. Then electrolyte monitoring and ABG monitoring should be done every 4th hour. Urine output monitoring should also be done. And also then after once the sugars we already decreased, the acidosis resolved, bicarb everything more than became 18, pH resolved, sugars are around 180 or something. I already discussed how to overlap. You can take the last 6 hours cutting, last 6 hours average. Let's say 1 unit per hour is going, you can multiply into 1 into 24, like 1 unit per hour, it can go into 24 units, 80% 20, you can get 40% of it as a baseline, other 60% as bolus. So how do you overlap? So we got, let's say the patient is going around 1.5 milliequivalents per hour in the last 6 hours averagely. So that will come around 1.5 into last 24 hours, it comes around 36 units. So in that, if you take 80%, it will come around 28 to 30, let's say 28 or 30, it's up to 28. Some 29 units it will come. So in that 40% we took, like let's say 15 units you are giving it as glargine or any degludec. So how do you overlap this case per se? So first what we do? So first we will calculate the dose. Then okay, this is 14 units I am giving it as basal regimen, that is glargine or Tresiba. Next rest 16 units I am giving it as bolus, that is 5-6-5. 6 is a late afternoon because it is a major meal. So that is how what I decided. So I want to give glargine. This is how do you overlap? How do you stop the infusion? So you got glargine, you have a regular medicine, you got also food with you. So what will you do is first you give glargine therapy. So first you give 14 units of glargine. You continue infusion for 1 more hour. You take the insulin, like you take you give insulin of regular or no rapid. If it is no rapid, you give 5 minutes before food. If it is regular insulin, you give 20 minutes before food, and ask him to get food, give the insulin infusion, ask him to it. After half an hour you can stop the regimen. So at least overlap of at least, they say 2 hours, you can at least give at least 1 to 2 hours, you should give the overlap with basal regimen, so that patient won't have going to go into recurrent DKAs or something. So and also, so you give glargine, you continue infusion for at least half an hour to 1 hour, you ask them to get food. Before food, 5 minutes if it's no rapid, 20 minutes before if it's regular, you give regular insulin, you ask them to eat. After half an hour to 1 hour, you can stop the insulin infusion rate. So that is all. Glargine, insulin or regular or no rapid, food after 1 hour you can stop. So at least 1 to 2 hours you will get overlap. So this is how you overlap the insulin and then monitor the sugars. So this is how you actually manage a case of DKA. I hope you understood, and thank you.